Hello, I'm Ken Kinter, an assistant professor for Rutgers University. This is the first of a series of PowerPoint presentations on trauma-informed care, 3 steps to safety and OARS. The purpose of these trainings is to help keep people trained at Ann Klein and Ancora. In the event that I can't do the training, it's not intended that this be used as a substitute. However, it can help keep trainers informed. So again, this is the first in a series of 3 that will cover these PowerPoint materials. You have my contact information if there are any questions about this or if you need the handouts that accompany it. So we're going to start by talking about trauma-informed care, which is an area of increased interest in the mental health system. So in order for there to be trauma, there needs to be an incident that's perceived as highly threatening, something that potentially endangers the physical or emotional well-being of a person. Some of the most common examples that we see have been combat veterans or people that have survived physical or sexual violence. It's interesting to note that 2 of the populations that have actually taught us the most about trauma and PTSD are combat veterans and children who have faced physical or sexual abuse. One of the things that led to this field of study in the first place is the idea that these 2 totally different groups of people actually experience very similar symptom constellations through what they've been through. So trauma is an area that people tend not to want to talk about because if we're going to work on your trauma, then I may need to look at my trauma. And also the idea of we have people who have problems already, and by digging into their trauma history, we may fear that we're adding to what they're having to deal with. When the reality of the situation is trauma is usually at the core of what many people have to deal with. So it's in fact necessary that we go there to help people be safe and to be able to move on to wherever their next step is going to be in the mental health or legal system. So regarding prevalence, the reality is that probably most people in the U.S. have been exposed to at least one traumatic event. 1 in 10 Americans are diagnosed with PTSD over the course of their lifetime, and between 3 and 4% in any given year. Now, here are some of the common traumas that people experience. 1 in 5 experience sexual molestation. 1 in 4 beaten to the parent where the point where it left a mark. There's an asterisk. We'll come back to that. 1 in 3 couples engages in physical violence. 1 in 4 grew up with alcoholic relatives, and 1 in 8 witnessed their mother being beaten. Now, interesting point to that one is the violence doesn't need to happen to you. Witnessing it is sufficient. In fact, in some cases, witnessing can make it even more complicated. Think about it. If you have a loved one, would you rather have them beaten in front of you or have you take the beating for them? Different people would answer that different ways. Now, let's get back to that second one. Couple generations back, being beaten by your parent till it left a mark was pretty much acceptable and not a big surprise. Also, some cultures, physical violence to the point of leaving a mark is more acceptable than others. So trauma is a little complicated in that there's a cultural frame and there's a generational frame. Not everyone who's been in any of these situations is necessarily traumatized by it, but it is one of the ingredients that makes up trauma. Now, and actually one of the other interesting factors about this is it isn't the extent of violence that determines whether something becomes traumatic or not. Sometimes it's a feeling of betrayal. Combat veterans tell the story of it's not violence that necessarily caused the trauma, it was the feeling that they shouldn't have been there or that they were needlessly put in harm's way or they weren't backed up. Children who have been physically or sexually abused, very often they have a sense of betrayal around it was either a caregiver that was the perpetrator of the abuse or where was the protector? Where was the adult that was supposed to be keeping them safe and didn't keep them safe? And that's what turns a trauma into something that's more like PTSD. Because as we said, not everybody who experiences trauma does it go into full-fledged PTSD. There's other factors involved. So let's talk about the people that we serve in psychiatric hospitals. The PTSD rate is 20 to 40%, 10 times higher or more than in the general population. In fact, there's been some research that indicates that pretty much everybody in a hospital has some symptoms of PTSD because during the course of a hospitalization, people witness violence or participants in violence or the victims of violence. So there's a certain amount of PTSD that may come with being incarcerated for one reason or another, either psychiatrically or legally. Now, also, people that are mentally ill and have addiction issues may have been more likely to experience discrimination, poverty, to be around mental illness, to be around addiction, to be around all these very trauma-friendly situations growing up. And there's also a theory that it's not one traumatic episode that causes PTSD, but the idea of we all carry a trauma load. We've all experienced a certain amount of trauma in our life, and the more trauma we've experienced makes it more likely that a subsequent trauma might lead to PTSD. We give you a couple examples that are not strictly trauma related. Say in the case of a bereavement, okay, it's not so unusual that people die. However, there are some situations that might make a death harder to deal with. If the person's younger, if the person died suddenly, if the circumstances around it were tragic, or if the person actually witnessed the death instead of hearing about it, all of these things can make it more likely that that bereavement will become complicated or harder to get past. Same thing with trauma. Just the idea of something is violent or potentially dangerous isn't sufficient by itself, but other circumstances can make it so, including previous access to trauma. The example I like to give was a 7-Eleven was held up many years ago. Guy came in the door, fired a bullet into the ceiling, and proceeded to rob the cash register after telling the two people that were in line to get on the floor. So they did get on the floor. As soon as the guy was done the robbery, he takes off. The one guy gets up, he starts laughing, and he starts calling everybody on his cell phone saying, "Oh my God, I can't believe it, the place was just robbed." He probably had it on Facebook 5 minutes later. The other person stayed on the floor and was crying and shaking, and as a result, had some PTSD symptoms. Both these people were in the exact same place at the exact same time with the exact same experience. However, their responses were completely different. And I'm willing to bet that what that had to do, two things. One, that person ascribed a different meaning to what happened. And the other one is, I'm guessing that person had other traumas going on in the background that connected to this one to create a PTSD reaction, the increase in that trauma load. So in the case of Ancora, we've underdiagnosed PTSD pretty significantly. Last I saw, we had about 5 people out of 400. And that is really low, lower than the general population. Some of that is, as of the time of this recording, we haven't really systematically looked for PTSD across the population. Another aspect of that is that many of the clients that are in our hospitals have some pretty clear symptom profiles that take precedence over it. If someone's hearing voices, if they're having mood swings, if they have an intellectual disability, that's a lot more visible. So it may be difficult. PTSD might be in the background, very much a driver of what's going on, but not the first thing that you see that's visible. And I'm not sure what the numbers are at Ann Klein regarding prevalence. So as we mentioned, trauma can turn into PTSD. PTSD is not extremely rare certainly in our population. And here are the necessary ingredients: potential threat to life, serious physical injury, either to that person or a witness. In some cases, the witnessing it is more difficult than if it actually happened to you, because we've seen this in servicemen as well. Feelings of intense fear, helplessness, or horror, fear of loss of life or well-being. And that the symptoms continue for at least 1 month past the incident. So again, if there's a death near you, being depressed, having a tough time for a little while is understandable, but if it extends for a longer period of time, that may be an indication that it's becoming what they call a complicated bereavement. Same thing here. You can experience a traumatic incident. It's okay that it affects you. You see the picture on the screen. I'm sure for many of us in this area, 9/11 affected us pretty significantly for quite some period of time. But if these symptoms are still there and still causing impairment after a month, then we look at the diagnosis. So regarding the diagnosis of PTSD, some of the things that you're looking for are avoidance, and that is that the person kind of tries to block this thing out and block out anything that has to do with it. So they want to stay as far away from this incident as possible, or anything that reminds them of it. If you think about the example of a Vietnam veteran who doesn't want to be anywhere near helicopters or doesn't want to be around on the 4th of July when fireworks are going off. Might be a pretty good example of that. So people are on alert all the time. So they don't do well at engaging in other activities. They don't see themselves as having much of a future, and they don't engage in other things. They're pretty preoccupied. So increased arousal. As I mentioned, if someone's adrenaline system is kicked up all the time, it's very hard to focus, very hard to participate in other things, very hard to concentrate. The person is on startle mode all the time, so they're very easily stunned. They may be quick to anger, quick to angry response. Again, your sympathetic nervous system is supposed to be set up like an on-off switch. There's the threat, it turns on, you respond to the threat, and then your system dials down again. Somebody who has PTSD, they've been stuck on the on switch for quite a long time, and our system really isn't meant to operate that way. So what we find is that trauma, we've sort of shifted from not talking about trauma to where we are now, which is talking about trauma-informed care. And the leading edge in the research is indicating that it's really trauma-centered care. Trauma seems to be the core of a lot of psychiatric, addiction, and even medical problems. So we do have to assess that in treating patients. So there's something called the Adverse Childhood Experience Scale, which you may have a handout for, or you can find it online by looking up Adverse Childhood Experience Scale. And basically it's a list of 10 pretty common adverse things that can happen to children growing up. And basically it's a list of 10 things. If you meet the criteria for one of those things, you score 1. If not, it's a 0. So you may end up with a score of anywhere from 0 to 10. And what they find is that 1/3 of the people taking this scale have had no significant adverse childhood experiences. The other 2/3 have. And that when you start to get into 3 or more, as you see this 20%, then interesting things start to happen. A person starts to be at higher risk for things, mental health issues, addictions, medical problems as well. And so this speaks to the point of trauma being central to someone's health and well-being. So here we are with a score of 4 or more, things start to get interesting. Now look at the increase in COPD frequency, 390% increase, hepatitis 240, depression 460, attempted suicide over 1,000. So the higher these scores get, the more trauma load a person's carrying and the greater the possibility that it's impacting them in some way in their life, particularly in the area of their well-being. So we see here there's a bit of a shift going on. We don't want to ask people what's wrong with them. We want to ask what happened, because what they're doing may be a normal reaction to a traumatic event. If you watched your mother being killed in front of you, there may be things that upset you, and that's, we don't want to over-pathologize that. We want to work with the person to be able to understand what happened to them and how it's going forward. Because most people who are dealing with trauma and PTSD don't even realize it, or they've ascribed it to something else. And then what happens is something new comes along and triggers that old thing, and they ascribe it to the new trigger as opposed to something that was old. I'll give you an example from a hospital that I worked at. We had a woman who was about to be discharged, and she was in a music therapy group. And a male patient was playing keyboard, was playing a piano. And turns out that this woman had been sexually molested by her piano teacher. So when this patient, I don't know if it was something to do with this patient or the music or the piano or whatever, she became very upset, screaming and yelling, causing this big scene. So she was triggered by her old trauma, the molestation, and responded to it. But now what's going to happen is now she's going to get to the point where there's going to be a code, people are going to be called, and there's a possibility that she may be held down, physically restrained, and receive injectable medication. Now, can you see somebody who's been through the kind of trauma she's been through, how this would actually re-traumatize her and add to the trauma that she's carrying around because of this? So this is part of the reason why we're doing something called universal precautions for trauma. Now, you know what universal precautions are. You don't assume that someone is contagious or not contagious. You glove up regardless. You assume everyone is contagious. Well, the plan with universal precautions here is you assume that every single person you're working with has been exposed to some sort of abuse or violence. And you want to acknowledge that and let that shape your interventions before you put your hands on somebody. Before you run the risk of re-traumatizing them, work with them so that you can avoid the re-traumatizing process of this. Now, here's a list of pretty standard things that can be triggering for people. Again, many triggers are very individual. Some triggers are more general. And it's our job as the people that are providing care to know what triggers our clients and what helps bring them back to normalcy again. Because what could be triggering for one person might be something that someone uses to recover from a being triggered on another. For example, a dark, quiet room might be traumatic for one person. It might be exactly what another person needs. So that's kind of our job to know what will help them. So in closing, the most important point of this talk is the idea of universal precautions. Assume that everyone has been traumatized and work with them accordingly so that we can avoid re-traumatizing them. A side note of that is it's also helpful if we know our own trauma load. Now, we're not necessarily going to share that with the patients, but in order to be effective, we should know what our own stuff is because it's going to overlap with the people that we're working with. And we can't take good care of anyone else if we're not taking good care of ourselves. There are also references. So at the third presentation of this, the motivational interviewing one, you can look at the end and they'll have all the references about this. And again, you have my contact information, you have my phone and my email on the first slide here. Please don't hesitate to reach out to me if you have any questions about this or if there's anything I can do to help you going forward. Take care.